3 and 2 and 1 and welcome to the Anatomy of Therapy. I'm Dr. John Cybulski here with Bobby Riley today, and today we've got a unique episode. Nothing crazy. I'm actually quite interested to hear Bobby's opinions on some of these things, but we're going to dive into it. We're not going to talk about hinging. We're going to talk about hinges, not door hinges, pivoting points, perhaps. How would you describe it, Bobby?
I don't know. I mean, besides the word hinges, I mean, we know this from spinal hinges. People use the term, there's a spinal hinge. I've heard McGill use this. I've heard FRS, like, the Spina, that group, talk about hinges and segment, the reverse of that would be segmentation. So if you had a spinal hinge, it's kind of saying that there's a segment or a joint of, two bones in the low back, for example, that are doing the majority of the movement, whether it's inflection or extension, throughout that spectrum on the spine. So instead of, like equal movement between the joints, you're getting most of the movement between a single joint. So
does it relate outside of the spine? So like immediately I'm thinking of just generally like the knee, the elbow. Can those be harder to knee, the elbow, are those hinges?
Well, there's the nomenclature of, physiology or anatomy and physiology. We have hinge joints, or jinglemus, I believe it was originally, is the original term. But
Watch your mouth.
Hinge joints, but I'm using this in an informal way. I'm sure there's somebody else that refers to this as a hinge in all parts of the body. You can call it whatever you want. Mm-hmm. A hinge, a bend, a crease. I don't know. Hinging just sounds the best to me.
Yeah. What's the significance? Like, why are we calling it a hinge? Why are we talking? So is the hinge, like, let's say L5S1 is hinging too much? Is that kind of the direction to speak about a hinge and saying that they're not hinging together, or like the isolated hinge is a problem?
Yeah, it's more of an uncontrolled hinge, which would be something that I would be concerned with. But to be honest, I would say most hinging is that way. So I'm not talking about a hip hinge to do a proper kettlebell swing or something like that. That is a hinging movement. I mean, that belongs in a different topic or a different discussion. I'm saying that when I see patients and I look at them, I see a variety of hinges going on. Hinges is just the English vernacular for what I'm trying to describe.
Got it.
We can call it whatever we want. But I see hinges. I just see them in the body. So, but the real easy one to understand, especially if you're familiar with something like the FRC or FRS, would be the spine. So, if you put somebody in a cat camel, cat cow, whatever, put them in that all fours, go into flexion, go into extension, the FRC system would kind of say, hey, why don't you see if you can segment those, or is that all happening through just a few joints? So they will have something like try to roll just the sacrum into flexion, and then L5, and then L4, and then L3, and then L2, and work your way up. And then can you reverse that? So somebody who can, that's called segmentation. So anybody who can segment quite well doesn't mean that they don't have a hinge problem in their spine, but it does clear the fact that we do know that they have the ability to segment. I would typically say it's more likely to happen in somebody who can't segment very well between all their joints, so they're doing it primarily through a joint or through one axis of a joint. Like this subtalar joint, for example, or it could be the talocrural joint where you have calcaneal eversion, so much so that you can't ever really access, a great stance in that leg, or you can't get certain muscles to kick in. You can't get rid of that bunion on the big toe, or whatever's going on. You can't it's hard to fight that hinge that's going on through the axis of that ankle, to disallow that movement so you can access something new or something that you need.
Got it. Okay, so quick question. So this is something that you'll see in patients. I like the idea of the spine and seeing it also maybe in the heel. I'm sure in other places as well. If you were to discover these things, so is the test for this, like you're saying, the cat cow, cat camel? Like I think I've seen West Side Barbell guy like in a reverse hyper, having a guy kind of extend his legs, but then he's pointing to particular segments and he's like, move here. Now he moves his hands up a segment. Now move here. So would you test the ability to, like a tactile, hey, can you push your back into my hand, or can you move your heel into inversion, away from me or into me? Is that the test to discover these, or are you finding these just, watching them walk down your hall? Or
no, that's a good question. I would think that those tests are actually to prove or disprove the fact that they can access their joint, not necessarily if they're hinging or not. So
okay.
So you're looking to see, can they segment their spine? Can they evert and invert their foot? Can they plantar flex? Do they have, three-dimensional control of their ankle or their knee or whatever it is? But honestly, you may have somebody, for example, who has fantastic mobility or movement in their knee in all directions, in all planes. They can rotate it, they can bend it, they can extend it. But you'll find that they hinge in stance, maybe into a hyperextended knee state. When they stand there, they're just, knees are locked back. So I'm just, again, this is just my vernacular on this topic, just trying to group these things together. But if I see somebody standing there with knees locked back, I could say, I'm not going to write this in my notes necessarily. I would just write hyperextended knees, but I'm seeing a hinge going on there in one direction. And if they have a real hard time, like, can you unlock your knees for me? And then they feel like they're doing a quarter squat just by unlocking their knees. I can tell they're very unfamiliar with not being hinged backwards in that position.
Understood.
Yeah.
So like, let's just say, let's go back to the spinal one. That's just, I think, easier to visualize for the cat cow, rounding your back or flexing and extending your spine. So let's say you just see somebody standing and their back is super arched. They're in the J-Lo kind of position. You go into the all fours position and you go segment by segment. Can you counter nutate your sacrum back and forth? Can you kind of guide them through that? And they can. And you go to L5, S1. Can you flex this part? Can you push up? Now, can you get away from me? And then you just say, you go to L4, L5, and they can't do that. They kind of go back to S5, S1 or L5, and they can't seem to hinge through, let's just say L4, just as an example. What do you do then? What does that tell? What does that tell me as a clinician?
Well, I would say it's kind of, we should expect this a little bit. It's our genes, for example, they don't wear evenly, equally across all of the pants seams and threads. They wear where the stress is. It's not a good thing, because if it did wear evenly, we could definitely wear our pants until they turn into one of those like t-shirts that are translucent, transparent almost, so thin because they're so old. But that'd be nice. Our jeans would last longer before we tear them, but it's kind of expected that there's going to have stress points. So in 2020, I'm not surprised that, we don't have perfect segmentation, or that you are going to have a hinge spot. And that's why the FRC guys and their whole system exists, because they're trying to say, hey, you have a joint that is operating at 30% or 80% of its full capacity. And whether or not you think you need those ranges, you most likely do. And
Mm.
movement is the key to joint health. And if you can only access 20% of it, well, that's definitely not moving. That's not healthy. Let's get it moving. Now, but with that said, I shouldn't expect everybody to segment well. These hinges are like a clear, like waving yellow flag to say this is a stress point, and this is
Mm.
something you should look at to see if it's going to prevent you from getting them better or progressing them. Is this going to be something that's going to stop their recovery process? Is this thing going to thwart everything that you throw at them rehab wise? Is it going to
Mm.
laugh when you try to do manual therapy on it, or whatever it is kind of tactic you throw at it? These hinges, I'll tell people, there's no way 3 sets of 10 or my little thumb is going to win the battle of the other 23 hours and 30 minutes of every single day that you go do something against what I'm trying to accomplish.
Right.
So, and we know this with respiration, right? We breathe 20, depending upon how healthy you are, 20 to 30,000 times a day. And that can be helping somebody or it can be hindering somebody. And you're not going to win the battle if they're breathing poorly 30,000 times a day against what, what you gave them, which was, 3 sets of 10 every other day if they have
Right.
time.
Yeah, no, that makes sense. Okay, so further questioning, turning the light to grill you. So this week I had a patient and I was kind of walking them through a clam, basically, more or less. It was a little bit of a, if you're familiar with PRI, it was the right glute max. So basically they're doing what looks like a clam, except instead of going knees straight up, they're rolling their right leg forward and then it's kind of going up. When I do that exercise, PRI Nation, oftentimes I will allow them to I'll just cue them to that. I'm like, we're doing a clam, you're going to roll your right knee forward and then lift it up. And if you've done that exercise before, you know that commonly it will fail the first time and they won't feel their right glute max. But I almost kind of let them not feel their right glute and I'll ask them where they feel it. And commonly it's like the right low back, the right QL, one of those little hinge points in the back. And it's a little bit more complicated way to get towards that hinge, but I'm like, look, you are trying to move this right hip forward, flex this right pelvis, abduct and externally rotate your right femur. Yet for some reason, the strain is hinging into that spot in your right low back. And so going back to the camel, like I would have them then, round their back through kind of that unhinge, if you will, in that right low back. That would be the first cue. There's another bit where the pelvis kind of comes up and it might laterally hinge as well. But correcting that hinge, then we do the exercise again. If they can maintain that hinge, then they'll feel their right glute. Is that kind of along the same lines?
Yeah, that's good. I mean, that reminds me of I think it was our last podcast where we talked about a client or patient of yours who just was on the end ranges of his joints all the time, whether it was in sitting one direction, standing the other. And we discussed that we thought, in our opinion, it was a good idea that he worked a lot of mid-range strength, finding sense from the floor, finding sense in his balance without using joint end ranges so much. At least in the hinges that we're talking about here, he was hinging in his low back and pelvis, or hinging in his knees, we were talking about, in his upper back, probably in his head, or the OA joint at the top. So yeah, I mean, when you can kind of try to pull somebody out of a hinge and then use a muscle, like you were saying, is a good idea. I mean, if you have I even thought of these, you ever look at a shoulder and you see one does not look like the other? Even if you're looking at them from the front, you can almost see this like crease through their, like coming out of their armpit. It's like a very subtle one. And it's almost like it's almost like you had a bit of Superman vision where you can pull away the skin and you can see a pec minor that's pulling that scapula forward, and there's no opposition in the back, and they have maybe a flat spine and the sternum is moving towards that same area, and you're like, that's a hinge right there. And to train shoulder strength on that thing is going to be rough. And I have a gymnast right now that was recently sent to me because of like 2 years of struggling through a shoulder episode or episodes. And I just look at her and that's what I see. I see this hinge, this right shoulder that is in a state of hinging, I guess, to keep using the same words. And sometimes it's very difficult to say, where do we start with this? How do we pull somebody out? I said this on that last podcast with your guy. How do we get people to get out of knee hinging and stance? That's difficult sometimes, even if he has the mobility, even some strength. Well, now there's still a neurological component of sense and awareness and, this vestibular kind of awareness problem where people just use those hinges to find themselves in a sense, to establish their posture, to hold themselves up, to rest, to read, to sleep,
Yeah, absolutely. No, I couldn't agree more. I think my first response to that is basically, they're using those joint capsules, which are highly innervated, and give the body a lot of feedback as to where it is in space. So I don't, a lot of people say, what am I doing wrong? And yes, pain is wrong, but it's more so just an impulse, a signal to tell you, hey, ease up. You know what I mean? So I don't like to put a moral tag on it to be like, you are sitting bad person. You know what I mean? They're doing that for a specific reason. And if we can kind of understand that reason, we can find a similar reason. We need to give you a reference to upright yourself, to hold yourself up. So I had a patient this week, this woman was talking about sitting upright, and she was like, I could just tell after we were kind of doing one of a similar glute clam with her, and she was like, I could tell kind of the shift in my pelvis. I feel a little bit more aware of it yet during the clam, but when I sit, I just know I need to kind of arch my back to sit up straight. And I was like, I understand where you're going with that, but I gave her the reference of her sit bones, her ischial tuberosities when she sits. So yeah, you can arch your back and forth, and maybe it looks a little bit more upright, but the reference is still the spine primarily, rather than the base of a pelvis. And so for me, I like to give them at least one kind of simple reference for when I sit. And it's not easy still to find those little sit bones when you're rolling back and forth. They'll immediately say, well, my butt's not that bony or something like that. But giving them something like with the foot, it's really easy. Going back to your hinging at the heel, the inversion, eversion problem. To find and feel a specific part of your heel is challenging. I've talked about kind of me doing my wall squat test, and you had a great post the other day on our Instagram page. Follow us, like us, share us. But about squatting, and you were kind of cueing some of the things as you were going down and as you were going up. One of the things I like to test when people are squatting is, do you just generally, I'll start here, do you feel more weight on your right leg or left leg? And you can kind of see their eyes roll back in their head, and they're like, right leg. Okay. Well, more now on your right foot, do you feel more on the front or the back? And you see them search again. So like, they don't have a very immediate reference, and to ask them to put 75, 80% of the weight on their heel can be very challenging at first. But then slowly kind of getting them to get some awareness there as they are going up and down through that squat. I'd be interested to ask you about that post you had yesterday with that squat. What were you trying to do with that? First, kind of tell the people, good people, what the squat was, and how that kind of relates.
Well, that one is kind of tied. I mean, I didn't directly talk about hinging or anything or hinges, but we could use that one to directly tie in a hinge problem, maybe preventing you from descending into a full squat. Because I think at the end of my comment under the post said something like, thank goodness we have toilets in 2020, most of us anyway. because in order to do a full squat and go to the bathroom, you need to be able to segment your spine. You need adequate ankle mobility, adequate knee and hip mobility. You need your spine to be able to flex. Like, and I know there's some anti-flexion people out there, and sometimes that's substantiated, actually. There's times when flexion is a bad choice for somebody. But for a healthy spine, I mean, I don't know why flexion would be bad if we have to do it to go to the bathroom. We have to do it to, bear children. We have to do it to, it's like our resting position before we built things like lazy boys. And so this exercise was just me. It's pretty simple, just holding on to a railing. I had posted a video a few days before that without a railing, just holding kettlebells and trying to protract that weight forward with through my elbows. And instead of having to actively do that, you could just use a railing and then walk yourself back so that your arms are protracted. When your arms protract, your thoracic spine retracts concomitantly to just create that position. And then if you had a bit of an ankle issue, that would also be a good idea to put something under the heels, because in this particular exercise, I'm not trying to train ankle mobility or flexibility. If I was, that's a different topic, but I'm trying to train, just end range squat. So to get somebody to be able to squat again. So if you take somebody, and I had a patient this week that was prime this problem, like a L2 hinge, just extreme, like cannot get out of extension at that point. They're going to have a real hard time squatting deep. They'll hit a certain point, maybe I would guess she's probably 10 degrees above parallel at best. They're going to hit this point where they go, well, what do I do now? How come I can't? So what do you feel? Like, I don't know. I just can't go any deeper. Okay. Well, one of the reasons you're hitting this point because you can't reverse your pelvis, because now I'm not talking about squatting with 400 kilos on your back. I'm just talking about human natural squat, right? And she's not able to reverse her pelvis because she's not able to reverse her lumbar curve. She's not able to diminish the lordosis, which needs to occur, obviously, to do a full squat. So, and one of the ways that, you could help that is by at least establishing some thoracic flexion above it, which is what I was doing in that post, by hanging onto the rail, letting my weight fall slightly back, and then using keeping my abs on to help support that position. Maybe I didn't have anything under my heels, but you could, and then allow yourself to descend into a squat. And I made sure I held that position all the way up and all the way down, pushing through my feet. And, for this particular lady I was mentioning as an example, this would not work because she has no ability to flex like L2 on L3 or whatever, exact segment that was. Mm-hmm. So there's a different task for her to try to prevent that, to, let's say, break away from that hinge. But she's a prime example. This is actually a little bit where my idea came from, was there's just no way. I mean, I can have her lay on her back with her feet close to her butt, flat, like hook lying position. And I can say, I put my hand at L5S1. I'm okay. Can you smash my finger? Okay. She can do decent, not great, but she can push down on it. L3, L4, sure, she can push down. L2, it's getting tough. And that upper lumbar, there's just nothing. She can then push down her thoracic spine, or maybe T10, T9, but nothing in that other area. She's not able to get it down. So you can look at, and in her case, there's reasons. You say, well, why is the hinge? Is it mainly joint? Is it muscular? Is it all of it all tied together? She's somebody that happens to have a pretty bad spondy, by the way. And you could really focus on that spondy, to be honest, but she actually is able to segment there decently compared to a little bit above it. So I think that area above it is really smashing her spondy below it. But yeah.
So like so with an intervention in terms of something like that, like I can just hear listeners, they're like, okay, so she can't smash there. What do you do, man? Like, I'm thinking immediately, for whatever reason, to go the opposite way and get her abs to engage, to kind of push back. Like the back can't smush your hand down, then I would put my hand on the top of her ab and say, kind of get away from me, which would engage the abs. But what did you do, Bobby?
Normally that would work.
Yeah.
She's somebody who sits on like a short step or stair to tie her shoes, and she can't breathe. She's somebody who, when she bends over, has to hold her breath until she comes back up. And if she gets panic attacks, and sometimes she'll have to put her arms over her head, like reach up to, towards the heavens to all of a sudden take a breath in. And this is this is a big thing we're working on is, she's been to manual therapists and massage and physios, and there's not a lot of external force, I think, by itself that would fix this issue. And with her, they got the crural fibers of the diaphragm that go down around this segment where she has a hinge. So L1, 2, maybe 3 at the most for these crural fibers. And if I can get her in a position where she can pull those fibers, we might have a chance to basically flex those levels on each other. Because if I get her in a position where those posterior fibers that are basically going down to the ventral or the front portion of the vertebral bodies, if I can get those to pull upward and flatten her lumbar spine, we can do it internally. And there's times when external works, but all evidence shows that alone was not working for her. There's no amount of TFM. There's no amount of, percussion guns out there that would do anything. It would make her feel better, but then, just have her walk down the hallway and she's back. Have her take a few breaths in, just deep breaths in, and she's back, because she can't do that. That muscle is not helping with that. So the trick is, can you get her just into a position enough to feel that? So, but you put her in just dead bug position and she can't breathe and shakes and has to collapse. You can't use it. Like, her abs can't pull that rib cage down in the front. There's no strength there to fight this hinge.
Yeah. Interesting. That's fascinating. I've seen these patients before, like, where they're just neurological. And so back to the kind of FRC stuff, Dr. Spina, Dre, had a post the other day on Instagram where he was talking about the histology kind of muscles, and a muscle or a segment kind of, let's just say muscle being tight, I think it was what he was saying. And if you don't discover particularly why that area is tense, whether if it's the global position of the joint or a movement in particular, that oftentimes you can do more damage by trying to percuss it, to do manual therapy, to push your elbow into it, to foam roll it, lacrosse ball it, if you don't kind of see the wider reasoning for that. But then he was also kind of talking about, and I know it was kind of part of a larger conversation, it seemed like, because he was jumping around a little bit, annoying, but be thorough, explain everything. But it was clearly part of a larger conversation where he was saying, now, if you're an FRS practitioner, what you would do is find a particular angle, and then you would start to move it through ranges of motion. But it was still kind of unclear exactly what the intervention was. The major point was that there are muscles and joints that will be tight for particular reasons. And this is a good reason. He didn't really go into the reasons, to be perfectly honest. He didn't really go into the interventions, but he was basically saying muscles and joints will be tight, and you'll do an intervention and it'll do nothing. And I think we've all kind of been, I don't say guilty of that, or we've kind of all experienced. I've worked, let's just say, here's a good one. We were kind of talking about this. Well, we weren't talking about it because I was busy, but you had a patient with a neck. And necks are very much like this. You'll have a tiny little segment that's annoyingly tight. And you can kind of get some range of motion. You can loosen them up generally, but they'll still be like, God, there's this one little spot that's super annoying. And it just won't go away. No amount of praying, wishing, no amount of lit candles and prayers to St. Mary are going to help it, unless you can kind of see that wider picture. But at the same time, like, is there that hinging point? Because we are talking about neck cars. I think even with Dr. Loke, going through like neck cars, big range of motion with it and feeling little points that hurt. With things like, let's say, even with the woman, I guess we can kind of stick with that versus the neck, because the neck is going to be that's another hour to get into. But with an intervention like that, she probably needs some more internal pressure and internal control. But can you go through, back to what we started with the FRS, can you go to like segmenting the control of her, like her just kind of going through a slow cat cow? Like, it's a longer intervention and she's got to do it every day and control herself, like those t-shirts say. But, or does she work on the internal pressure?
Well, it's definitely very multifactorial, and that's
Sure.
the difficult part. And like what Dre was saying, he was talking a little bit about mechanical tension versus neurological tension.
Okay.
I'm sure that's what you were hitting on. That's
Yep.
what they hit on a lot in FR. And he does do this great, which we should say, marketing savvy. Let me just touch on things without ever giving any real deep information so that
He's
you
good
have
at
to
that.
come to my course or buy my products. He's very good at that.
Smart. For sure.
Yeah. But anyway, I think that sometimes that works if you can access the joint. This is where, sticking with the cars and stuff, if you have these closing angle pains, that may mean that you have to do an intervention before you can work on the joint. So sometimes if we all know this with an ankle, if you're saying, hey, you need more ankle mobility, and they're saying, well, when I try, I just jam the front of my ankle, it feels like I'm pinching my bones together.
Mm-hmm.
Well, you can do all the kettlebell on knee, banded Kelly Starrett stuff you want, but that thing is just running into itself. You might just end up with a bone spur in a year, and then can't do any squatting after that. So you definitely have to. This multifactorial part is something that we can't talk about on a podcast. This is something that takes years and years and years of experience, where you can start to quickly or more methodically start to peruse the person's issues and be able to throw certain things in or out, and that's what Spina, he is good at that, in the sense of where he's saying, okay, if it's not mechanical tension, then what are you doing with your thumb and with a blade, a metal blade and stuff like that?
Mm-hmm.
Because if it's neurological tension, it's neurological tension. It means it doesn't need any kind of force to go into it. It's neurologically driven, which means it's going to be there after they take a breath in or they say a word. Nothing is going to, you have to attack that differently from something that's mechanical, like a true portion, like a fibrous portion within a gigantic bundle of tissue that may be restricting full range of motion.
Right.
So like on this lady, it's multifactorial in the sense it's a double-edged sword, or it's a snake eating itself. There's a joint that's probably has no segmentation, and it hasn't flexed in years. Now, due to that, there's a whole cascade of issues. Poor pelvic floor, poor ability to internally rotate the rib cage, therefore weak abdominals, and then a hyperactive or strong ability to hold extension through really strong TL muscles. And you say, okay, what am I going to do for this person? And like you said, one thing that the FR people, don't maybe tell you up front is, hey, you're going to have to do a lot of this all the time for a really long time, and then you'll get it. He does say that. They do talk about that, like, do your cars every day. But on the surface, it's not like you don't do joint circles. They know they hate that term, circles, but you don't do these joint rotations, and then all of a sudden you can, you have a beautiful shoulder. This is, some of these athletes who are pro athletes, they're talking about half of their training is doing these things. It's a lot. So where can you succeed with the patient? So for her, she's not the person that says, I'll do anything, give me more exercises. I'm running 100K in a month. I'm also, I have a bunch of other side projects. I go 20 hours a day. I don't even need to sleep. She's the opposite of that.
Okay.
She's more like, you have to be kind of careful with her. Don't give her too much. Don't give her 3 things. She doesn't do any of them. Give her 1, but she has to kind of enjoy that 1, or has to be able to be easily set up within the house. Otherwise, it's probably not going to get done. So you can't throw these crazy DNS or PRI exercises at her, because she's not going to do it.
Right.
So if I can just get her in a position that she can breathe in, and then give her 1 or 2 things to feel. When in her case, I'm trying to reduce the hinge at that area. It could be successful if we're even getting her to breathe better, less panic attacks, drop her number down of discomfort 1 or 2 levels. That's fine with me for a short-term goal.
No, that's some high level clinician stuff when you can realize that sort of thing, because there are the hard and fast, I'm the doctor and you need to do these 3 things 5 times a day, only right after you eat, but not before you have your coffee. And you have to, I've just kind of realized that that's just not going to work. You need to set your patients up for success in terms of that. And hopefully you're aware enough to see where they're at. And at some point you do need to be the doctor and give them a little bit like, hey, maybe that's just how I work. And if that's not going to jive for you, maybe we need to find somebody else. But going back to the neurological tension versus mechanical tension, the isolated thing where a percussive instrument does work, because there are people out there with silver blades who do help people, and they have felt a lot better after they've scraped the heck out of their upper trap. And like, you do feel, let's just say, even if it doesn't fix it fully, a lot of times the Graston stuff, the percussive stuff, the manual therapy stuff will make them feel in that area more. And sometimes just directing a little bit of feeling of sensation, an extra bunch in that area, can help. Not all the time. It might not be the perfect intervention, but the patient will get a more of larger sensation in that kind of area that they're hurting. So we kind of bash on that stuff a lot, but it does have its place. And even if it is for a second, people are like, okay, I can tell something's happening there. And it sometimes, honestly, for me as like a younger clinician, it would buy me some time so I could figure out what the heck I was going to do. It still kind of does for me, to be honest. I don't always know what to do, but let's just say if that's the mechanical tension, you've grasped in somebody and that's worked. And say they get some relief, right? They're not one of these patients who are really terrible. They feel 50% better maybe, and they're like, awesome, thank you, let's keep working at this. If they are more of that neurological tension, I think, let's go back to earlier, you were talking about your squat, and you mentioned something about putting something under the heels. Even when you were talking about the squat, you were talking about feeling the weight go down through your foot. So versus doing some isolated Kelly Starrett ankle mobility stuff, bands pulling you one direction, lacrosse balls jamming on your posterior tib, that would be the isolated mechanical stuff that might shake things up a little bit. However, if that ankle joint is neurologically locked up in relation to, say, gait, stance, a flexion, a squat, or a lunge, then, so let's say you do the mechanical input, they feel a little bit looser, they walk down the hall and back, they go, oh, it kind of came back a little bit. Okay, that's a clue that it's a little bit part of a larger issue. Great. You go back, you loosen some stuff up again. Great, it feels great. Now, for me, immediately after kind of giving it, they say a window of opportunity. Some people don't agree with that. Fine, if that helps you, great. Loosen it up and then go back to those larger neurologically stimulated things like your squat with a heel raise. So now you've given them some dorsiflexion mechanically in the isolated joint. Now, can they use that dorsiflexion with triple flexion of the knee and of the hip, right? Can they incorporate that small mechanical thing with a larger chain? It can be straightforward and back, and I think that's kind of the place to start sagittally. Bill Hartman had a great post. He's had a lot of them lately. If you haven't followed him, follow him, on a side to side. So we're talking about inversion and eversion. And yeah, you can kind of evert or invert the foot and heel as you go through a straightforward squat, but he kind of had a lateral lunge where you were like doing a groin stretch basically. You shift your weight over to the left. You act like you're sliding down a wall, but you're keeping your weight on your heel and the inside of your arch and kind of maintaining that inversion through a more global lateralized flexion. And so that gets a little bit more complicated, but I would just say if you get some of that isolated unhinging, whatever that may be, whether it's the shoulder and the pec minor thing, the low back, if you can quickly incorporate that into a larger global movement, you can kind of get these localized mechanical things with your hands, with your tools or whatever, but then shift them into some of these movements are harder, yes, these larger neurologically grouped movements like a squat. Is that fair to say?
Yeah, I mean, there's a lot to unpack there.
There's a lot to unpack there, but
yes.
trying to go from the small thing to the big thing, it doesn't always work, but that's the idea basically.
Yeah, I mean, I think the gist of what you were talking about was, you can control for the mechanical variable and then enter into a neurological approach if you have access to it to kind of retrain something new. And I think that's what we're talking about here with these undoing these hinges, so to speak, is
Right.
waking up and accessing these proprioceptors and mechanoreceptors and GTOs and all these different things that have been kind of dormant because you or the patient or whoever we're talking about has been accessing certain ranges only all the time. So that, of course, they're going to hinge into these positions because those are the cells, those are the tissues that know how to say, hey, here I am.
Right.
You're balanced, you're standing, you can stand up right now because these are the tissues that you are familiar with. And you tell somebody to bend their knees and they feel like, oh my goodness, like I feel like I'm working so hard just to stand up right now. Because they're just entering into a new strategy just to recruit different pathways just to stay there.
Right.
So, and this is where, this is what the FR people do, is they're trying to say, you need to try to express the joint in a sense of accessing as many cells as you can for those function to occur, right? And going back to the little bit of scraping and stuff makes them feel better, or some releasing some stuff, quote releasing, makes them feel better. I'm not sure, I don't want to speak for those guys, but I'm pretty sure somebody like Spina would say, I'm not really sure why our goal is always to reduce pain. Like, I don't think his focus is on pain per se. His focus is, pain is not really a function measure. It's really just a expression of that, like just a single measure of how you feel. It's not really a functional measurement. So I think he would say, well, that's great that they feel better, but does their arm move any better? Because that's going to give us a long-term result. Right. So, yeah.
That makes a lot of sense. To go back to, we were talking about positions to make them successful and incorporating a bunch of different muscles. I think that's one of the reasons why, if you ever see those FR guys doing their exercise, you'll often see them like clenching their fist really hard when they're moving their arm in their big kind of windmills. Even when they're moving their legs, like say they're going into the 90-90 position. And so let's say that 90-90 position where they're kind of sitting and their legs, one leg is flexed into external rotation, one leg is an extension and internal rotation. And they'll kind of bring their chest over their knee and maybe they'll lift their back leg up, but you'll still see them flexing both of their hands as hard as they can. Oftentimes they're flexing their face and all sorts of other things. But even in that 90-90 position, if they're bringing their chest over their front leg, they're locking up one leg and putting that leg in a position where it can't do very much. Your weight is over it. And that back leg has to really recruit a lot of different muscle fibers to do what it normally does in another situation. Like, for instance, I imagine like the woman you had, a lot of PRI people like to do the short seated position to kind of get them to breathe through their back, or, bring their ribs down and in without having to mechanically think about it, because that can be a very odd thing to like, what do you mean move my ribs down? And that I know how to move my hands, but I can't primarily move my ribs. But short seating is basically like having them sit on a little tiny stool or something like that, where their knees are kind of above them. They're almost kind of passively down in the bottom of a squat, but they're just sitting on a stool. You can kind of have them rock back onto their hips and kind of work on kind of breathing there. But putting them in positions that strategically lock them up. So like that 90-90 position is trying to get hip extension through one side while the other side is actively doing some movement. And that's kind of one of the things, and they just have to work on that and work on that and work on that. But locking them up into a position to force them to recruit new things is kind of the general first step, I think, into this.
Yeah, it's just trying to control for compensations, basically.
Correct.
I mean, one of the reasons they're squeezing their fists so hard is because some of that stuff's very tough. But the irradiation that you're seeing is basically to make sure that you're moving where you want to move.
Right.
I mean, you'll just have somebody do a shoulder rotation, and you see them just leaning away and hiking their shoulder, and they're not really accomplishing the task. So by squeezing everything else, you're kind of focusing that effort in a certain spot. And I think there would come a point for that, like for the spine and segmentation for this lady. But at first, it has to be more of what you were just kind of hinting at, which is more of a passive position to put her in, just so she can just begin to unlock that hinge.
Yeah.
And I think,
go ahead.
I just wanted to say, I mean, I think for people that are still wondering about this, we're talking about a specific hinge here, but I mean, there's just hinges all over. And I just wondering, I'm just kind of saying, see if you can't notice them in all parts of the body. Like, I was writing a little bit of a list down just really quickly and came up with a pretty large list, right? Everything from hammer toes to everted calcaneus to OA joints to jaws to, scapulas and spine. And so you'll start to see these in patients, and that might be a good idea to see if you can correlate those hinge issues with the problem that they actually have. Is it tied to it? Is it preventing them from doing something? If they can't unlock a hinge like this lady, but there's somebody like a CrossFitter and they're getting FAI all the time, the inability to reduce that hinge may be the reason why all other approaches that you're doing on that hip is not reducing their FAI symptoms. You're doing tons of hip capsular mobs, and you're stretching it and they're pigeoning it all night long, but when it comes to it, they don't have the pelvic, thoracic, lumbar ability to reduce that, or maybe they don't have the ankles to reduce that hip compression in the front.
No, absolutely. I mean, even on investigation, I've kind of noticed it's pretty obvious. Let's just say we are manual therapists. Looking at those, you were talking about your jeans kind of wearing out is a great example. But in the same sense, there would literally be kind of wrinkles in the body. I mean, if you just look at the front of your elbow, those kind of wrinkles, basically, right? At the wrist, you'll see that wrinkle usually at the bottom of the sternum, in the abs, where people hinge over at the bottom of their sternum and fold. The neck, there's a lot of those kind of fine kind of little folds, basically wrinkles that'll give you some clues into where they're hinging, other than specifically where they will kind of tell you where they're hinging. I wanted to get briefly into it, but it's going to have to be a whole other episode. Going back to what you were saying about putting them in a position to lock them up, and then going back to FRC, where they do a lot of end range kind of contraction. I don't know if you've kind of seen some of them where they're, I guess the easiest one to describe would be like a sitting on the floor doing a hamstring stretch. Like you would sit and you would just reach down for your toes, where they would be sitting, reaching for their toes, and then they would lift their foot up off the ground while they were fully flexed in that position. So they'd be working on hip flexion in maximal hip flexion, basically. And initially when that happens, it's really hard to like, reach down for your toes in that seated position. But then after that, engage and use that hip flexion at the end range. End range strength would kind of tell you a little bit about the joint that it's connected to. But again, that would be also kind of putting in a position where it couldn't. And we'll have to get into that another time, I think. But that is one of their other quick little strategies, because he is very coy about giving away all the gold. That's not all the gold either, but kind of working on situations like end range strengthening basically is one of the keys, I think. Yeah. Anything else before we wrap up here, man? A lot of gems through this dude though, but I mean, I like Hinges. I mean, I don't think about it often in that sense. I think maybe indirectly some of us kind of get there, but I think kind of just naming the problem actually helps quite a bit. So, but yeah, anything before we close?
No, I just, I guess I would close saying, this modernity that we live through is gonna, it's kind of the new normal. So it doesn't mean we should go diagnose every hinge we see and tell them, you have this hinge here, you have a problem, we need to work on it. I mean, you have to see if it's clinically relevant. There's a good chance it might be, but I mean, I don't know. I've told some of my patients, they say, well, why do I have this? And how do I get rid of it? And how come I have a dowager's hump? And I say, you know what, if you just woke up, slept with your partner, walked around all day looking for berries and tubers and water and built fires all day, and then you just scaled, fish, and then, did a full squat to cook your fish over that fire you built, we just would be mainly treating acute injuries all day long. You know what I mean? Right. We wouldn't, people who fell in a hole, you wouldn't have a lot of these hinges and patterns, but hinges are formed when we have repetitive stress and trauma, right? Those genes tear in a certain way because you always sit a certain way, or you always move a certain way, and that happens. And so it's something I've been throwing around, it feels like a lot in the last couple of weeks, is 2 lines, which is, one is just pain is your body's demand for change, right? That's one of them. Another one I've been telling people is, the only bad posture I know of is one that never changes. And I'm not the first person to say these or be aware of these things, but these are 2 sentences I've just been constantly, seems like, based on the people that are coming in right now, I've been throwing at them to let them understand, like, hey, in your scenario, sitting up super straight is just going to make you worse. In your case, you have to understand that that's what you're trying to do all the time. That's not what you need. It's okay to just Netflix it. And then they sit back in their chair. I say, can you just relax back in your chair? Ask them a few more questions. I say, how's your mid back feeling now? And they say, actually quite nice. All right. Because the pain was the demand for change, and the posture changed, right? We weren't stuck in one position, and she felt better. So yeah, I guess I would just leave with that and use this hinge idea to however you want to use it. But it might be we all need a system for evaluating the world, and it's just another system. It's just a little micro system that you can use to pick up on patterns, which can help you identify things.
Yeah, and I think that's kind of the whole point of this show, man, to kind of help people to broaden horizons, to break out of things and hopefully see things in a new light, to give people a wider option of ways to help the people that they see all week. Anyways, thanks y'all for tuning in. I'll learn how to speak more gooder next time. Peace.
Thank you, guys.